were thrust into the world of pediatric nephrology when I was 27 weeks pregnant. During a routine ultrasound at my OBGYN's office, it was discovered that I had no amniotic fluid as a result of Stephen's kidneys failing. Based on the ultrasound technician's images and measurements, his kidneys were extremely enlarged and echogenic. My doctor's initial thought was that it might possibly be a disease called autosomal recessive polycystic kidney disease, or ARPKD for short. The resulting news from my doctor was devastating. There was no way that Stephen could survive. Without amniotic fluid for that length of time, he wouldn't have any lung function, and there wasn't anything that could be done to reverse the loss of fluid. Later that day, we were sent to a specialist that would take a more in-depth sonogram and confirm the diagnosis, ARPKD, and gave us more grim news about Stephen's prognosis. From there, we sought out physicians who were recommended to us by other physicians and children's hospitals that were ranked top among the nation. We had some truly awful experiences at some, and then we found a glimmer of hope with a pediatric nephrologist here in DC. He gave us the grim news that we had been hearing all along, but then he gave us the reality of what can be done for a child with end-stage renal disease: removal of the deceased non-functioning kidneys, dialysis, and transplant. Finally, we found a physician with some answers. Now that, of course, is the 10-second version of the conversation. The much longer conversation was that Stephen would be really sick for a very long time, and that not only would my life dramatically change as a new mom, but I would also be Stephen's caregiver. And it would be a long and extremely hard road to get Stephen to transplant. But none of that mattered to us. We finally had some solid evidence from a medical professional that we could do this, that as long as Stephen had enough lung function to breathe at birth, they would remove both of his kidneys, place a dialysis catheter in his abdomen, and he could live at home without any kidneys on dialysis until he was big and strong enough for a transplant. Unfortunately, you're not able to deliver at Children's National, and transporting Stephen by air at birth was out of the question. So from there, we obtained second and third opinions at Inova Fairfax and Children's Hospital of Philadelphia, two hospitals both with high-level NICUs that could handle Stephen's level of care. In the end, we decided to stay here locally, and I delivered at Inova Fairfax under the condition that we would have a team of physicians in place already at his birth that understood his needs and that could handle all of those issues at his birth. And in the meantime, my husband and I made preparations for both the good and bad outcomes. On January 4th, 2011, Stephen came into this world breathing and ready for a fight. At 6 days old, during extremely long surgery, a surgeon removed both of his kidneys, placed a peritoneal dialysis catheter in his abdomen, and a feeding tube in his stomach. After 59 long days in the NICU with lots of ups and downs, he came home and so began our journey through dialysis. Dialysis was very hard on Stephen's little body, and he was very sick. He was on 12 hours of dialysis every single night when a machine would pump a sugar-like substance into his abdomen. It would sit there for an extended period of time at intervals that we put into the machine, and then the machine would pull back a dialysate back out of his abdomen, and it acted as a replacement for his kidneys. It was my job to set up the machine every night, connect him, run diagnostics on the machine when it went haywire and alarmed all through the night, all while dealing with a screaming infant, and unhook him 12 hours later every morning. There were no home dialysis nurses to provide assistance, and there was no on-call dialysis nurse from our nephrology clinic to call at night when things went wrong. Stephen was frequently sick with infections, seizures, GI issues, respiratory issues, and a whole laundry list of diagnoses. We were frequent visitors at Fairfax Hospital, and each time he was admitted to the emergency department or for an inpatient stay, it was our responsibility to bring his dialysis machine to the hospital, and I was in charge of hooking up his dialysis machine and unhooking him each morning and night. and also directing the emergency room nurses and doctors on how to take a peritoneal dialysis sample from his catheter. Imagine having to call 911 in the middle of the night because your child's having a seizure, and then concerning yourself with packing up his dialysis machine before getting into an ambulance. As you can imagine, it was extremely troubling to my husband and I. You expect, especially when your child is admitted to the hospital, that the hospital has the staff and knowledge to perform a procedure that you're asked to perform every single night at home. We were most concerned with what would happen in the event of an extreme emergency and we were unable to be there with him if we got into an accident or something terrible. So at one point I trained both my mother and my mother-in-law to be backups to us in case of an emergency or just to get a break for a night. As a result of doing so, I was unfortunately reprimanded by the nephrology clinic dialysis nurse for doing such. On top of dealing with all of the medical issues, I spent countless hours dealing with insurance issues between Medicare, our private insurance, and Medicaid. Stephen was required to have Medicare because of dialysis, but when issues arose between who was responsible for what, or why certain medications were covered by one insurance and then not covered by the next, and I had to call Medicare to sort those issues out, it was a battle with them as to why an infant was even on Medicare in the first place. The conversations went somehow like this. There was a process of explaining why they couldn't speak to the Medicare recipient, well, he's 5 months old. How was I authorized to speak on his behalf? Why he had Medicare, and then ultimately most of the time they were just unable to help me at all. It was a constant battle, and unfortunately it's still to this day. And the pediatric social workers just don't really have any experience in dealing with Medicare, so I was pretty much stuck to navigate the insurance world on my own. Then, once we hit the 30-month coordination period between Medicare and our private insurance, Medicare became primary. And it was almost worse in some regards because there are no pediatric providers, except those that practice in a hospital setting, that accept Medicare. So every time we go to the pediatrician for a simple cold or a well checkup visit or an immunization, we're required now to pay cash out of pocket at about $200 a visit. If I want to have a basic office visit or something as simple as a flu shot covered by insurance, I'm forced to take Stephen to a county vaccination clinic or urgent care where they accept Medicare patients. And it shouldn't be that way. We have private insurance. We pay our private insurance premiums. And when I attempted to find a nurse for Stephen so that I could work 1 day a week or get an aide for him so he could go to daycare and get his tube feeds at school, there are no pediatric nursing agencies that accept Medicare. And because I never did get that nurse or an aide for Stephen, we were just informed in February that he lost his Medicaid waiver eligibility, and the state of Virginia will no longer pay his Medicare Part B premiums that help to defray the cost of his immunosuppressant drugs. Come this May, he will be 36 months post-transplant, and he will also lose his Medicare. We will have to rely solely on our private insurance for all of his doctor visits, immunosuppressant drugs, frequent blood work, and hospitalizations. It's an extremely scary prospect for my husband and I, knowing that we will reach our deductible and likely our out-of-pocket maximums each year. Having lost his Medicaid, I already know that we'll be responsible for some of his durable medical equipment that was only covered by Medicaid. But more than anything, it's the immunosuppressant drugs that are most important. The medications keep his body from rejecting his new kidney, which has given him a quality of life that cannot be measured. Without those drugs, like you've heard, he would lose his kidney and be back on dialysis. I have spent a little bit of time traveling to some of your offices over the past couple of years, speaking to staff members about the importance of some of these issues, especially the comprehensive immunosuppressive drug coverage bill. This bill will give transplant recipients like Stephen access to Medicare for a longer amount of time, past the current 36 months, to receive assistance to pay for their drugs. Paying for a transplant recipient's drugs is by far and away much cheaper than paying for a kidney patient to remain on dialysis. Not only do the drugs keep a patient off of dialysis, but maintaining a healthy transplanted kidney maintains a patient's overall health and well-being, keeping overall healthcare costs low. This leads me to another point that Dr. Perlman mentioned earlier, and that's the Living Donor Protection Act. I can't leave here today without briefly sharing the story of how Stephen received his new kidney and how he's able to be here with us today. Because Stephen, my husband, and I are not Stephen's blood type, Stephen's O positive and we're both A positive, he got all the great recessive genes from us. We couldn't donate a kidney to him. So he could be listed for a deceased donor kidney, receive a living donor kidney, or be listed for a paired exchange. It's another very long story. I won't get into it here with lots of ups and downs. But ultimately, Stephen received a non-related living donor kidney from my husband's college roommate's wife, Kristen Freeman. Kristen and her husband and 3 young girls live in Wilmington, North Carolina, and Stephen's transplant was in Philadelphia. This amazing woman gave up time with her children and her husband, time away at her job, and took on the risk associated with this surgery to save my child's life. I know it sounds a bit dramatic, but it really is the truth. She saved Stephen's life, and really not just his life, but she gave me back mine as well. Kristen is an amazing human being. She got nothing in return from the selfless act of helping another person, not a penny. And there are so many people like her in this country doing this, we hope, every day. The numbers don't show that, but we hope. For family members, coworkers, friends, and complete strangers. We've all seen the Facebook posts and the news reports about people giving kidneys to complete strangers. The Living Donor Protection Act is so important because it gives the living donors and their families just a little peace of mind that the risk they've taken for this person is not in vain. That in fact, they won't be penalized for their selfless act of kindness. And I think if it gives someone contemplating donating a kidney just a little extra nudge in that direction, that's a bonus too. As you've heard, every single one of the issues discussed by today's panel have impacted our family. From workforce issues in the pediatric nephrology field to Medicare and insurance policies and lack of funding and research. There's much improvement required to understand the needs of this important patient population, and we're just one family among many throughout the country with similar stories. I hope that our journey has shed a little light upon life with pediatric kidney disease, and I greatly appreciate you taking the time to hear our story. And Mr. Stephen, would you just come up and say hi to everybody? Because this is the most important part of our story together, right? All right. And this is Stephen. He turned 5 in January, right? And what's the best